हाँ जी, वो कनेक्शन ही लॉस हो गया अचानक से, रुक गया, 1 घंटा हो गया ना। हाँ, अब ये रुक गया 1 घंटे में। पता नहीं। नहीं नहीं नहीं। हम्म, नहीं नहीं, स्टार्ट है। कोई चेक इट। Okay, sorry for the interruption, guys. Well, can join back. So I was discussing filariasis. Suddenly the connection went off. Sorry for the interruption. Let's begin again, guys. So I was discussing filariasis. Are you guys back? Can you just comment it down? Yes, yes, it started. Okay. So let me discuss about the filariasis, guys. If I talk about filariasis, we have two agents called as Wucheria bancrofti. We have Wucheria bancrofti and Brugia malai. And the test that we do for filariasis, my dear students, you will remember the test name is membrane filtration test. The test name is membrane filtration test. Okay, and if I talk about the treatment, if I talk about the drugs or the treatment of this filariasis, we have 3 drugs. Okay, how do you remember the triple therapy, guys? AID. Okay, this this AID triple therapy is for albendazole. It's for filariasis. What are the 3 drugs? Albendazole, ivermectin, and diethyl carbamazine. And diethyl carbamazine. These are the 3 drugs that we use in treatment of the filariasis. Okay, so one other question question that the examiner can ask from the pathological aspect. So remember this, guys, I'm putting this image here. Okay, the examiner can ask is the presence of the nuclei. Okay, we know that we have Brugia we have Brugia malai and Wucheria bancrofti, both of them. So how do you differentiate, guys? If the tail tip shows 2 terminals, if the tail tip shows 2 nuclei in the terminals, it will be Brugia malai. And if there is no nuclei at the tip, it will be Wucheria bancrofti. And this is a classical picture of the filariasis. Can you see, guys? This is the classical picture of this is a classical picture of filariasis. Okay, and what is the treatment, guys? 3 drugs, triple therapy, albendazole, ivermectin, and diethyl carbamazine. Okay, it was about filariasis and leishmaniasis. I will I will again discuss a bit leishmaniasis, guys. The test that we do is RK39 dipstick test. The intracytoplasmic inclusion bodies that we have are called LD bodies. Okay, L. donovana causes visceral leishmaniasis, and L. tropica causes cutaneous leishmaniasis. Okay, the drug of choice is L-amphotericin B, and this L-amphotericin B is also a drug of choice for mucormycosis. Okay, remember that it's also a drug of choice for mucormycosis. And one more condition, guys, cryptococcal meningitis. So all the severe fungal infections, the drug of choice is L-amphotericin B. Okay, now guys, let's discuss the next question. Okay, so it was all about filariasis. Now the question is from the food adulteration diseases, guys. So we have to remember what is the toxin, okay, what is the agent, and what is the food stuff. Okay, so let's discuss the food adulteration diseases. If I talk about first one, guys, lathrism, the toxin is boa. Okay, what is the toxin for lathrism, guys? It's boa. If I talk about agent, guys, it's kesari dal. The agent is kesari dal. And the food stuff, we have yellow pulse. And the food stuff, we have yellow pulse. If I talk about the second one, epidemic dropsy, my dear students, the toxin is sanguarine. The toxin is sanguarine. Okay, the agent is argemone seed. The agent is argemone seed, and the food stuff here is mustard. And the food stuff here is mustard. If I talk about endemic ascites, guys, remember the toxin of endemic ascites is pyrrolizidine. It's pyrrolizidine. The agent is Coroterilla seed. The agent is Coroterilla seed, and the food stuff is millet. And the food stuff is millet. If I talk about aflatoxicosis, the toxin is aflatoxin. The toxin is aflatoxin, and this toxin also causes hepatocellular carcinoma. This toxin also causes hepatocellular carcinoma. And the agent is Aspergillus flavus. Agent is Aspergillus flavus. Okay, and the food stuff is groundnut. And the food stuff is groundnut. If I talk about the ergotism, my dear students, the toxin is ergot alkaloid. The toxin is ergot alkaloid. Okay, the agent is Claviceps fusiform. The agent is Claviceps fusiform, and the food stuff is flowering plants. And food stuff is flowering plants. Okay, so remember, guys, if I talk about lathrism, the toxin is boa, the agent is kesari dal, and the food stuff is yellow pulse. Epidemic dropsy, you have to remember the toxin as sanguarine, the argemone seed is an agent, and the food stuff is mustard. If I talk about endemic ascites, you have to remember the toxin as a pyrrolizidine, the agent is Coroterilla seeds, and the food stuff is millet. If I talk about aflatoxicosis, the toxin is aflatoxin, which is associated with the hepatocellular carcinoma. The agent is Aspergillus flavus, and the food stuff is groundnut. If I talk about ergotism, guys, there is a toxin ergot alkaloid. The agent is Claviceps fusiform, and the food stuff is flowering plants. The simple question was asked, guys. A factory worker had a history of frequent exposure to the groundnuts. He had an exposure to the groundnuts. Subsequently, he develops hepatocellular carcinoma. The most likely exposure is aflatoxin. Okay, guys, I've already discussed, guys, aflatoxicosis. The toxin is aflatoxin. Number one thing, guys, the agent is Aspergillus flavus, guys. The agent, you already know what is the agent. Aspergillus flavus. Aspergillus flavus. And the food stuff is a groundnut. And the food stuff is groundnut, and it is associated with hepatocellular carcinoma. It's associated with hepatocellular carcinoma. Is that clear, guys? So if I talk about ergot toxin, that is associated with ergotism. If I talk about sanguine, that is associated with epidemic dropsy. If I talk about pyrrolizidine, that is endemic ascites. So it was all about food adulteration diseases. Is that clear? So let's move to the next question, guys. Okay. Now it's from the communication, guys. One of the methods of health communication where 4 to 8 persons are qualified to talk about the topic and discuss and given a problem or a topic in front of a large group in sequence. Okay, the method is called, simply, guys, 4 to 8 experts are delivering in a sequence. Okay, 4 to 8 experts are delivering in the sequence. Your answer will be, guys, let's discuss. If 4 to 8 persons delivering in sequence, your answer will be symposium. Simply remember, guys, sequence S for symposium. If, guys, 4 to 8 experts will deliver, but there is no correct order of speech, there is no correct sequence, no order of speech, or no sequence, that is called panel discussion. That is called panel discussion. If I talk about workshop, my dear students, by workshop I mean series of more than 4 meetings. Series of 4 or more than 4 meetings. If I talk about IPC, the best method of communication, guys, IPC, that is interpersonal communication. Interpersonal communication, that is the best one, guys. Remember, this is the best way of communication, guys. Remember the second thing, guys, there is a face-to-face communication, face-to-face or one-to-one communication, and this is the best one. Okay, then if we have 6 to 12 persons in a discussion, 6 to 12 persons having a discussion, such method is called as focus group discussion. We have one more, guys, that we do for an ORS, guys, called as demonstration. And what the principle you will remember for demonstration is: seeing is believing, learning by doing. Seeing is believing, learning by doing. It's called demonstration, and demonstration is mainly done for ORS. Okay. We have other ways of communication as well. Lecture method, guys, chalk and talk method. We have one more, guys, called as flannel graph. okay, where the series of photographs are pasted in a piece of a cloth and given the information, guys. We have one more called as spikes technique. Whenever we need to break the bad news, such technique is called as spikes technique, where we are taking the care of knowledge as well, emotion as well. Okay, we set up the interview and we deliver the bad message. For example, if the patient is having a lung cancer, so if you have to tell, if you have to convey, if you have to communicate that news to his family, the technique that we use to break this bad news is called as spikes technique. So this is the actually the Socratic and didactic method of the communications. But you just remember, guys, important ones that I've mentioned here. But keep it in a mind, if 4 to 8 persons are talking in a sequence, that is a symposium. 4 to 8 persons not in a sequence, no correct order of speech, there is no sequence, that goes with the panel discussion. Okay, guys, that goes with the panel discussion. So let's move to the next question, guys. The best parameter for assessment of acute malnutrition. Okay, the best parameter for the acute malnutrition. So remember, guys, if I talk about decrease weight for age, decrease weight for age, that is for acute plus chronic undernutrition. Acute plus chronic undernutrition. If I talk about weight for height, decrease weight for height, that is acute malnutrition. That is acute malnutrition or wasting. If I talk about height for age, decrease height for age, that is chronic undernutrition. That is chronic undernutrition or stunting. Stunting. So remember, guys, so for acute malnutrition, the answer will be decrease weight for height. The answer will be decreased weight for height. The answer will be decreased weight for height. So let's discuss two types of malnutrition, my dear students. Two types of malnutrition. What are the two types you will remember, guys? Kwashiorkor and marasmus. Kwashiorkor and marasmus. If I talk about Kwashiorkor, guys, there is low protein but energy is normal. Energy is normal. But in case of marasmus, my dear students, it's low protein, low energy. It's low protein, low energy. Okay, these are the two types of malnutrition you have to remember, guys. One is Kwashiorkor and one is marasmus. In Kwashiorkor, remember, guys, there is a low protein and energy is normal. But in marasmus, guys, there is low protein and low energy. Now, how to differentiate, guys? The faces that we have in Kwashiorkor, we have moon face. We have moon face. We have also moon face in which condition, guys? Cushing syndrome, right? Lemon on stick appearance, moon face. Okay. And remember, guys, there is a sign in the hair called as flag sign. There is a sign in the hair, flag sign. That means if there is a hair shaft, it is full black and in between it will be white. That is called a flag sign. Black, white, black. Okay. Then, guys, we have a bulging abdomen or protruded abdomen in Kwashiorkor. Protruded abdomen. That is a Kwashiorkor. Okay. In case of marasmus, guys, remember, guys, there is thin and brittle hair. The baby will have thin and brittle hair. Okay. There is a loss of muscle mass. Okay. Marasmus, it will be mara hua. Okay, guys. So you remember like that. loss of muscle mass. Okay, there will be shrunken abdomen. There will be shrunken abdomen. Okay, and remember guys, there will be old man face or simian face in the marasmus. There will be old man face or simian face. So these are the two types guys, kwashiorkor and marasmus. So you remember guys, bulging abdomen in case of kwashiorkor, shrunken abdomen in case of marasmus. Okay, moon faces in case of kwashiorkor and old man faces or the simian faces in case of marasmus. Is that okay guys? There is a loss of muscle mass more in case of marasmus, but comparatively lesser in case of a kwashiorkor. So that are the two types of malnutrition. And also you'll remember guys, decrease weight for age, you go for acute and chronic undernutrition. Decrease weight for height, you go with the acute malnutrition. And decrease height for age, you go with the chronic undernutrition. You go with the chronic undernutrition. Okay, so that was all about malnutrition. Let's move to the next question. Which of the following is the least complication of measles? Which of the following is the least complication of measles? So let's discuss the measles guys, very important. Let's discuss the measles. If I talk about the agent of measles, first of all, if I talk about the agent of measles, the agent is RNA paramyxovirus. The agent is RNA paramyxovirus. If I talk about the incubation period of measles, guys, it's 10 to 14 days. The incubation period of the measles is 10 to 14 days. The third part, guys, if I talk about period of communicability, that is that is 4 days before the rash and 5 days after the rash. So how do you remember guys? The agent is RNA paramyxovirus, and it measles, just remember guys, 45. What is 45? 4 days before the rash and 5 days after the rash, or 4 days before the rash. Sometimes some books write 4 days before the rash and 4 days after the rash. Okay, if I talk about 3 C's of measles, what are the 3 C's, my dear students? We have cough, we have coryza, and we have conjunctivitis. We have cough, coryza, and conjunctivitis. Cough, coryza, and conjunctivitis. Okay, and if I talk about the spots, we have white spots on the opposite to the second molar. And those spots are called Koplik spots. And those spots, my dear, are called Koplik spots. Okay, and there is a hyperpigmented line on conjunctiva. There is a hyperpigmented line on conjunctiva, and that line is called as Stimson's line. That line is called as Stimson's line. If I talk about most common complication, that will be otitis media. The most common complication will be otitis media. The other complications as well. Okay, most will be otitis media. The other complications as well, patient will have pneumonia, patient will have diarrhea. Okay, ये बाकी complications भी होती है. Okay, pneumonia and diarrhea. If I talk about rare complications, that is SSPE, subsclerizing panencephalitis. Subsclerizing panencephalitis is a rare complication of measles. Okay, Remember guys, the other hints guys, remember the vitamin deficiency that the patient of measles will have is vitamin A. Okay, is vitamin A. The name of the vaccine strain, the name of the vaccine strain of measles is Edmonster Zagreb. It is Edmonster. It's Edmonster Zagreb. Okay, how much to give, my dear students? 0.5 ml subcutaneous. And as per UIA, Universal Immunization Schedule, we give measles vaccine at 9 months. We give measles vaccine at 9 months. So it was all about guys measles. So which of the following is the least or rare complication guys? It is SSPE, subsclerosing panencephalitis. Is that clear guys? So remember my dear students, the agent is RNA paramyxovirus. The incubation period we have 10 to 14 days. The period of communicability we have 4 days before the rash and 5 days after the rash. The 3 C's of the measles, we have cough, we have coryza, and we have conjunctivitis. Okay, the spots that we have in the measles opposite to the second molar are called as Koplik spots. The hyperpigmented line on the conjunctiva is called as Stimson's line. The most common complication is otitis media. The rare complication is subsclerosing panencephalitis. The patient having the measles will have a which vitamin deficiency guys? Vitamin A deficiency. And the name of the vaccine strain is Edmonster Zagreb. Measles vaccine is given 0.5 ml subcutaneous, and as per the UIA, Universal Immunization Schedule. Okay guys, UIS. Okay, Universal Immunization Schedule guys. How much you have to give? You have to give measles vaccine 0.5 ml at 9 months. So it was all about measles. It was all about measles guys. Okay, we have also 3 C's of asthma. Remember guys, 3 C's of asthma as well. It might help you. 3 C's of asthma. Okay guys, what are the 3 C's of this asthma guys? Crayola bodies. We have Crayola bodies. We have Kirschmann spirals. We have Kirschmann spirals. And my dear students, we have Charcot Leydig cells. And we have Charcot Leydig cells. So remember guys, 3 C's of asthma. Okay, so it was all about measles. So the rare complication we have is SSPE. Okay, you just remember measles this much guys, that's more than enough for the exams. Okay, under ESIC Act, under ESI Act, okay, the sickness benefit given is a period of, for how much time will be the benefits? Okay guys, so let's discuss guys. If I talk about sick leave, if I talk about sick leave, that is given for 3 months. That's given for 3 months. Okay, or 90 days. And the salary that will be given to the patient for in this period of 3 months will be 70% salary. The sick leave will be for the 3 months or the 90 days. And how much that will be given guys? 70% salary. If I talk about extended sickness, if I talk about extended sickness, that will be given up to 2 years. That will be given up to 2 years, and 80% of salary will be given, and 80% of salary as per SIC Act guys will be given. If I talk about maternity leave, if I talk about maternity leave, maternity leave will be given up to 6 months. Maternity leave will be given up to 6 months. Okay, and the amount of salary in this period, in this 6 months, will be 100% salary. The amount of salary, the salary that will be given under the ESIC Act to the maternity leave will be 100% salary. Then the enhanced leave, If I talk about the enhanced leave, my dear students, we have vasectomy and tubectomy. We have vasectomy and tubectomy. For vasectomy, guys, remember the leave will be 7 days, and for tubectomy the leave will be 14 days. Okay. If I talk about disability, if I talk about the disability, guys, in temporary disability, guys, if the disability is temporary, they will give the leave till recovery. Remember, guys, they will give leave till a recovery, that is 100%. Okay. And if it is permanent, they will give pension as per the guidelines. They'll give pension as per the guidelines. Okay. And according to this act, guys, funeral benefits, and according to this, guys, the funeral benefits will be rupees 15,000. Okay. So that was all about ESI Act, guys. So it was saying that sickness benefit leave, that is a sick leave, guys, it will begin for how many days, guys? 3 months or 91 days will be the answer. Is that clear? So remember, guys, if extended sickness, that will be given up to 2 years. Okay. If I talk about the maternity leave, that will be given up to 6 months and the 100% salary will be given. If I'm talking about the enhanced leave, guys, for vasectomy it will be 7 days, and for tubectomy, guys, it will be 14 days. After that, guys, if I talk about disability, guys, temporary it will be the leave till recovery. Permanent it will be the pension as per the guidelines, and the funeral benefits will be rupees 15,000. Okay. Now, guys, one repeated question is here. Asha worker, okay, guys, Asha worker coming across a 40-year-old male with a history of fever, with a chills, ill and cachectic look during her house-to-house survey. Okay. What do I mean by house-to-house survey, guys? Surveillance. And when a health worker is going to the house-to-house for the surveillance, that type of surveillance is called as active that that type of surveillance is called as active surveillance. And if the patient is going to the hospital and taking the treatment, that type of surveillance is called as passive surveillance. Okay. For example, a patient is having cough fever, so वो hospital जाता है, hospital में treatment लेता है, and that type of surveillance is called as passive surveillance. And if there is a surveillance for exclusively for the sexually transmitted diseases, that type of surveillance is called as sentinel surveillance. So Asha is going house to house, guys, on suspicion of the disease which is caused by sand fly. Okay, the disease that is caused by the sand fly, and the disease, the Asha is going to home, and it is included in the national vector-borne disease. So we have a national vector-borne diseases. For example, we have malaria, we have dengue, we have Japanese encephalitis, we have filariasis, we have chikungunya, and we have leishmaniasis. So out of all those diseases, there is a one disease that is in the question given. Okay, she can perform the following tests. So which disease is caused by the sand fly, guys, or phlebotomous fly? Sand fly or phlebotomous fly, my dear students, which is mainly seen in UP and Bihar. Your diagnosis will be leishmaniasis. And I've already discussed the question on leishmaniasis. What is the test that we do, my dear students? RK39 dipstick test. Okay, guys, RK39 dipstick test. Okay. If I talk about peripheral thick smear, option A, if I talk about, guys, during the night time, thick peripheral smear, that is done for filariasis. Remember that, guys. Night time, one smear will be for the filariasis. If thick and thin smear, option number B, thick and thin smear. Okay, that is for the malaria. Who will take the smear, guys? Multi-purpose worker male. Multi-purpose worker male will take the smear. Okay, one more thing, guys. These two smear, one will tell me about the species of the malaria, whether it's Plasmodium falciparum, whether it's Plasmodium malariae, whether it's Plasmodium ovale, or whether it's Plasmodium vivax. One smear will tell me about the species, and second will tell me about the confirmatory of the malaria. We also go for the one rapid test in the malaria. We also go for the rapid test called as histidine rich protein test. Histidine rich protein test, and I also check LDH levels as well. That is for the malaria. Okay. So it was all about filariasis, guys. Leishmaniasis. So what is the drug of choice for leishmaniasis, guys? The drug of choice is L-amphotericin B. The drug of choice is L-amphotericin B. I have discussed this question above, guys. I have discussed all the things about this question here. Okay, you just have to recall it, guys. RK39 dipstick test. Okay, your answer was leishmaniasis here. Okay, so it was L. donovani, which is an causing the visceral leishmaniasis called as Kala Azar as well. L. tropica, which causes cutaneous leishmaniasis. The test that we do is RK39 dipstick test. The intracytoplasmic bodies, inclusion bodies that we have are LD bodies. The drug of choice is amphotericin B. How much to give, guys? 10 mg per kg with a single IV infusion. Okay. To check the immune status of the patient of leishmaniasis, we do a test called as leishmania test. Is that okay? And filariasis, I have discussed over there as well. The test that we do for filariasis is called as membrane filtration test. It's caused by Wucheria bancrofti and Brugia malai. And the triple therapy of the drug, we have AID. Okay, guys. We have albendazole, we have ivermectin, and we have diethyl carbamazine. And how to differentiate Wucheria bancrofti from the Brugia malai, my dear students? You have to remember there is no nuclei at the tip of Wucheria bancrofti, and there are two nuclei at the tip of Brugia malai. And we take a one thick smear. We take a one thick smear. I'm again writing here one thick smear. But my dear students, remember, this smear is taken during the night time. They will mention in the question which of the following is correct about the or incorrect about the filariasis. Okay, they will mention in the option the smear is taken in the night time, okay, or the morning time. So you have to remember it's not taken during the morning, it's taken exclusively in the night time. Let's move to the next question, guys. HIV positive mother. HIV positive mother who is taking the antiretroviral therapy treatment delivers a healthy baby with a birth weight of 3 kgs. Okay, so mother was positive. Mother was positive, guys. Birth weight of 3 kg, and the treatment was started just 4 hours after the delivery. Okay, which level of prevention is that? So if I talk about level of prevention, so let's discuss level of preventions. So let's discuss level of prevention. Okay, so in level of prevention, guys, we have pre-pathogenic, we have pre-pathogenic, and we have pathogenic. Okay, we have pre-pathogenic phase and we have pathogenic phase. If I talk about pre-pathogenic phase, my dear students, we have two things. Either we have a primordial prevention, or we have a primary prevention. Either we have a primordial prevention or we have a primary prevention. In case of a pathogenic, my dear students, we have two. We have either early secondary, or we have late tertiary. Okay, level of prevention, guys, pre-pathogenic and pathogenic. Okay, what do I mean by pre-pathogenic? Either it is before the disease. Okay, and what is pathogenic? Disease has occurred. Okay, so before the disease, the preventions that we can take, either we can go for the primordial or we can go for the primary. Now once the disease is occurred, either we can go for secondary or tertiary. So let's discuss them one by one, what exactly we mean by primary, primordial, primary, secondary and tertiary. If I talk about first one, primordial prevention, what do I mean by primordial prevention, guys? It's the prevention of risk factor to occur. Prevention of occurrence of risk factor. What do I mean by this, guys? For example, you have been advised that you should change the water of the cooler every week. Okay, if we will not change the water of the cooler every week, what will happen, guys? Mosquitoes will come. Okay, now the mosquitoes are coming, they are a risk factor for which disease? Malaria. So if I'm changing the water of the cooler every day, what will happen? Will the mosquitoes come? No. Will the malaria will have chances to occur? No. So whenever you are preventing the occurrence of the risk factor, such type of prevention, my dear students, is called as primordial prevention. Such type of prevention is called as primordial prevention. Now you are stopping the risk factor to occur. Now the risk factor is present. Okay, guys. Now the risk factor is present. Okay. Now the risk factor is present, but you prevent disease to occur. For example, now mosquitoes are there, but mosquito is a risk factor. Now you prevent yourself from the malaria. You are using the mosquito nets. You are using the insecticides. Okay, such type of prevention is called as primary prevention. Such type of prevention is called as primary prevention. So what is primary prevention, guys? Prevention of disease in presence of the risk factor. Prevention of disease in presence of risk factor. For example, I'll tell you the one more example. You have a HIV positive person, right? You have a HIV positive person. Now you know, guys, after some point of period of time, what happened to the CD4 count? CD4 count started decreasing. Okay, guys, and once the CD4 count is less than 500, we are having opportunistic infections. Now different opportunistic infections I'm going to teach you later on, but let me make you explain what exactly the primary prevention means. Okay, so after once the patient is having what? Once the patient is having AIDS, now he's more prone to the opportunistic infections. To decrease the chances of these opportunistic infections, we start the prophylaxis treatment. For example, if we talk about a very common example of a opportunistic infection that is seen in an AIDS patient, when the CD4 count is less than 200, we have pneumocystic gyrovasy. Okay, guys, now this pneumocystic gyrovasy, we know what is the drug of choice, my dear students? It's cotrimoxazole. And what is the prophylactic drug as well? Cotrimoxazole. So before prevention of the disease, okay, guys, in presence of the risk factor, what is the risk factor here? AIDS. Okay. What's the risk factor? Patient is immunocompromised. So patient is having AIDS positive. So he's already in the immunocompromised state. Are you getting my point? Now I'm trying to prevent the pneumocystic gyrovasy. That is an opportunistic infection which will occur due to the CD4 count decreased. I'm starting the treatment cotrimoxazole. So giving cotrimoxazole to the AIDS positive patient, to prevent pneumocystic gyrovasy, such type of prevention is called as primary prevention. So what was the risk factor, guys? Risk factor was the AIDS positive patient, but you are preventing the disease to occur. You are preventing pneumocystic gyrovasy to occur. That is the primary prevention. Is that clear, guys? So for example, here also patient is HIV positive, mother is HIV positive. Okay, now I'm starting the two drugs. What are the two drugs? What are the drugs that you start in the newborn prophylaxis in HIV positive, guys? Remember that, newborn prophylaxis of AIDS positive patient mother. We have two drugs called as nevirapine and zidovudine. Nevirapine and zidovudine, and minimum duration you have to give for 6 weeks. minimum you have to give these two drugs for 6 weeks. So remember, my dear students, you have nevirapine and zidovudine. Nevirapine and zidovudine. Is that clear? So these are the newborn prophylaxis. Now guys, mother is AIDS positive, risk factor is present, but you are preventing AIDS to occur in a baby, AIDS to transmit it in a baby. Such type of prevention will go with the primary prevention. Such type of prevention here will go with the primary prevention. Okay, now what is secondary prevention? Now it was a pre-pathogenic. Okay, primordial and primary was pre-pathogenic. Now let's discuss secondary. What do I mean by secondary prevention, my dear students? By secondary prevention, I mean that early detection and the treatment. Now patient is positive, all the investigations that you do, whether you do CBC, whether you do KFT, LFT, any single test that you do will fall under the secondary prevention. So early detection and treatment. Early detection and treatment, that is a secondary prevention. Now disease is present, you try to diagnose it as soon as possible. Such type of prevention will be termed as a secondary prevention, and the treatment given is also for a particular disease. Which level of prevention? Secondary prevention. Now let me clear it with a perfect example, my dear students. So for example, you have a patient coming to you, you have a female 51-year-old coming to you with a complaining of postcoital bleeding. Okay, patient is complaining of postcoital bleeding, or a 45-year-old female coming to you with a complaining of postcoital bleeding. Okay, now as per your a little knowledge from the obstetrics and gynecology, guys, you know the postcoital bleeding is a classical feature of a which cancer, guys? Cervical cancer is a classical feature of a cervical cancer. So what is your first step there? What is the first investigation you will send, guys? If patient is coming with a postcoital bleeding, guys, either you go pap smear or you go colposcopic biopsy. So pap smear and colposcopic biopsy here is a which level of prevention, my dear students? It is a secondary level of prevention. It's a secondary level of prevention when the disease is present. Okay guys, disease is present, you try to diagnose it early detection, or the disease is present, you are giving the particular treatment for that. Okay, for example, rifampicin, dapsone and clofazimine for the leprosy is a which level of prevention, guys? Secondary level of prevention. When the disease is present, guys, you are diagnosing it early as soon as possible and giving the particular treatment for that disease. Such type of prevention is called as secondary prevention. Sorry guys, I don't know, I'm feeling too much sick right now. I was not too much before, but now chalo guys, it's all about your understandings. You understand the thing, I'll take care of me. Chalo. Now one more thing I will tell you here. All the vaccines are which level of prevention? all the vaccines are primary level of prevention. But there is a particular vaccine, BCG vaccine, that is used for the bladder cancer. And using the BCG vaccine for the bladder cancer, that is a which level of prevention, guys? That is used as a treatment for the bladder cancer. Then the answer will be secondary level of prevention. But all the vaccines are primary level of prevention. Remember that. And all the investigations are secondary level of prevention. Now guys, the last one is tertiary. Management of complications and disability. Now in the end, guys, old age people, what they do, they wear glasses. In the old age. Okay, such type of glasses in the old age, guys. If the following, for example, patient was a diabetic, then he developed the cataract, snowflake cataract, and later on he's taking glasses, okay, to limit the disability, in the older age groups. Okay. So management of those complications. Okay, the cataract, the snowflake cataract was a complication of the diabetes. Now he's wearing glasses, he's wearing lenses for that. Such type of prevention is called as tertiary prevention. So understand one by one, guys. First, primordial prevention is a pre-pathogenic phase when you try to stop the occurrence of the risk factor. Okay, Then the primary is the prevention of the disease. There is a risk factor present, but you try to prevent the disease. Then the third is secondary, guys, and there is the early detection and the treatment. And the fourth one is the tertiary, the management of the complication and disability. Now the last question, guys. The STD kit. The STD kit used for the treatment of gripped painful vesicles leading to the painful ulceration over vulval area under the given program Suraksha Clinic. Okay, so there was a program initiated, guys, called as Suraksha Clinic. What was this program, guys? So let me write Suraksha Clinic. If I talk about this Suraksha Clinic, my dear students, it was a syndromic approach. It was a symptomatic or syndromic approach. Okay, so for example, what do I mean by symptomatic approach? For example, you have a patient complaining of the vaginal discharge. Okay, now you're not confirming what type of vaginal discharge it is. You're not confirming what is an exact diagnosis, whether it's a trichomoniasis, whether it's a bacterial vaginosis, or whether it is a candidiasis. So you're just knowing that it is a vaginal discharge. So based upon the symptoms, you are giving the treatment. Such was the strategy for Suraksha Clinic, not diagnostic. They are not diagnosing, they are just talking about the symptoms, and you're giving the particular drug with a particular kit. So here we have common symptoms, and we have some drugs inside those kits that will be given to the particular symptoms. So if I talk about kit 1, that is gray color. If I talk about kit 1, that is which color, guys? Gray color. So any patient will complaining of an anorectal discharge. Any patient will complain with complaints of anorectal or urethral discharge. You will give the which kit, guys? You will give which kit? Kit 1. You will give which kit, guys? Kit 1. And the medications inside the kit 1 are cefixime and azithromycin. Remember that. Cefixime and azithromycin. If I talk about kit 2, that is green color. Okay, guys, the green color kit, any patient which complaining of vaginal discharge. Any patient who complaining of vaginal discharge, you will go you will go with the kit 2 green. And the medications that are inside this vaginal medications inside the kit green, we have fluconazole, and we have secnidazole. We have fluconazole and we have secnidazole. Okay, guys, so any patient complaining of vaginal discharge, your answer will be kit 2 green color. Any patient with the complaining of urethral discharge, your will be kit 1 gray color. Okay, after that, my dear students, we have white color kit 3. So any patient with the non-herpetic genital ulcers, you will give kit 3. That is which color, guys? White color. But guys, these patients respond to penicillin. So the treatment will be penicillin. Drug will be inside the kit will be penicillin. Okay. If I talk about kit 4, my dear students, you have blue color. It will be again non-herpetic. It will be again non-herpetic genital ulcers. But my dear students, these patients will be allergic to penicillin. These patients will be allergic to penicillin. Then we have kit 5. That is red color. That goes with the herpetic genital ulcers. Herpetic genital ulcers. And the drug will be acyclovir in the kit. And the drug inside the kit will be acyclovir. Kit 5 will be red. Kit 5 will be red herpetic ulcers, and the drug for herpetic herpes will be acyclovir. If I talk about yellow kit 6, it will be associated with the pelvic inflammatory disease, PID, any lower abdominal tenderness, any lower abdominal pain, patient is coming, you are giving yellow kit, kit 6. Okay guys, what are the drugs inside the yellow kit? We have ceftriaxone, we have doxycycline, and we have metronidazole, and we have metronidazole. And we have the last kit, my dear students, kit 7. We have a last kit, kit 7, which is black color, that is for inguinal bubo. What is inguinal bubo, guys? Inflamed lymph nodes. Inflamed lymph nodes. And the medications that are in this kit, guys, are azithromycin and doxycycline. So here, guys, patient will have a group painful vesicles, guys, painful ulceration is there, herpetic ulcers are there, guys. Okay, so as per the kit, which kit you will give, guys? Which kit? Here the option is kit 5 for red. Okay, so the answer will be kit 5 red color. The answer will be kit 5 or red color. Okay guys, so for genital ulcers, herpetic, acyclovir, kit 5 red color. So you have to remember, guys, all the kits. So let's revise all the kits. So first of all, I talked about the kit 1, which is gray color. Any patient coming with the anorectal discharge or urethral discharge, you will go with the which kit, guys? Kit 1 gray. Then, guys, any patient with complaining of vaginal discharge, any patient with a complaining of the vaginal discharge, you will go with the kit 2 green. And what are the two medications inside this kit? You have fluconazole and you have secnidazole. You have fluconazole and you have secnidazole. Okay, now I have already told you, guys, this is a just Suraksha clinic is just a syndromic approach. Okay, and it is usually it is usually for the reproductive tract infections or genital tract infections. We are just taking the knowledge about the symptoms and we are not diagnosing it. For example, if the patient is coming with a vaginal discharge, now you have a greenish discharge, you will go with the bacterial vaginosis, or a greenish frothy discharge, bacterial vaginosis. Okay, you have a curdy discharge, okay, you go with the candidiasis. Okay, we are not diagnosing them properly, we are just getting to know about that patient is complaining of the discharge, vaginal discharge, and we are giving the treatment. Okay, so for the kit 2 green color, vaginal discharge. For kit 3, guys, non-herpetic genital ulcers that are responding to penicillin. Kit 4 is blue, non-herpetic, but they are allergic to penicillin. Kit 5, we have red, they are herpetic and treatment is acyclovir. Kit 6 is yellow color, guys. Any patient complaining with a lower abdominal tenderness, you will go with the kit 5. You will go with the kit 6, that is yellow color. And any patient with the inflamed lymph nodes, you will go with the black color, inguinal bubo. Now, what are the medications in the each kit, guys? If I talk about the first kit, we have cefixime and azithromycin. If I talk about the first kit, you have cefixime and azithromycin. Okay, if I talk about second kit, you have fluconazole and secnidazole. If I talk about third kit, you have penicillin, guys. Remember, mainly you have penicillin. If I talk about fourth one, you have azithro and doxy. You have azithro and doxy. If I talk about fifth, guys, you have acyclovir. If I talk about sixth, you have cefixime, doxycycline, and metronidazole. And if I talk about kit 7, my dear students, you have azithromycin and doxycycline. So that was all about. What about the dosage? You don't need to remember the dosage of the antibiotics. Okay, you just remember the kit. Okay, just remember the kit, guys. What are the kit and what is the particular drug inside each kit? Is that clear? Okay, so that was all about the high topics. So whatever the topics we are discussed, guys, sorry, Micah might have interrupted you guys, but yeah, it's okay. What matters is you have to understand the things and get the exam done on the 30th of the June. Okay, I will come up with a detailed topics, guys. It was just an high discussion how to approach the questions, and it would have been much benefited. It would have been much good for you if you guys have already revised such topics, but no need to worry about, guys. I have given you guys a detailed discussion for around 20 topics. Okay, 18 to 20 topics are covered, so please go through this, watch the video at 2x, and we'll soon upload some detailed discussions on the same channel. So if you have any doubts, guys, you guys can ping me up in the Telegram. Just only the study related doubts will be there. Okay, and there's a channel as well, FMG with the Dr. Talib Bilal. You can solve the everyday MCQs over there. Okay, I hope, guys, session was good enough and informative and productive enough for your exams. We'll be having more sessions very soon. Till then, take care, good luck, study well. Thank you.